Hello Fabrienne, how have you been doing lately? Not so good? But I'm glad to see you greet the audience again. After publishing her last video, more patients have contacted Fabrienne. She was asked many questions about galactose. Other viewers might have similar questions, and even if they didn't post them, Fabrienne wants to answer. That's what we made this video for. As a title, we settled for Does Galactose Really Help? But there's a bit more in here. First, we'll explain the idea behind chaperone therapy using the example of migalastat, a substance that is approved by the FDA and the EMA for the treatment of Fabry disease. Then, we'll do a brief comparison with galactose. An important point Fabrienne wants to make is that the mere fact that migalastat is sold as a drug and galactose isn't, doesn't mean that one works and the other doesn't. We'll finish this video with other random questions and their respective answers. Before we explain the therapeutic approach behind chaperone therapy, first a quick recap. Fabry mutations can be divided in two categories. The first category includes mutations causing a complete or near complete loss of enzyme function. In these cases, alpha-galactosidase A enzymes have to be supplemented using enzyme replacement therapy. There are, however, many mutations causing the production of defective enzymes. Mutations of the second category can also be treated using chaperone therapy. Chaperone therapy aims to reduce the defectiveness of a patient's own enzymes. As we explained in the second video about healthy cells, enzyme production involves stringing amino acids together in an order that is encoded in the corresponding gene, and then that string of amino acids is folded into a specific three-dimensional shape that is essential for the correct functioning of that enzyme. That folding doesn't just happen, but is aided by several smaller proteins that form a scaffold for the enzyme under construction. These smaller proteins are called chaperones. When Fabry mutations of the second category occur, the natural chaperones are not able to provide enough stability for this muted enzyme to achieve its optimal three-dimensional shape. This can affect several properties of the enzyme, like residual activity, thermal stability and pH stability. That's where pharmacological chaperones come in. Like natural chaperones, pharmacological chaperones are small molecules that assist in folding. Unlike natural chaperones, pharmacological chaperones assist in the folding of only a single or possibly a few proteins. As such, pharmacological chaperones are specific chaperones. Their presence allows defective proteins to achieve a better conformation, improving residual activity, thermal stability and pH stability. In the case of Fabry therapy, this is done by providing the developing alpha-galactosidase A enzymes with a molecule that mimics its target. Thus, these enzymes can assume a shape that matches the target molecule, even if the chaperone molecule is a bit different from the actual target. Now, we have described that alpha-galactosidase A enzymes aid in the breakdown of GB3, so we have to explain what GB3 is in some detail. A more detailed description will eventually follow in a video about sphingolipids, so we're just doing a little preview here. This section will involve some chemical drawings, and those will be explained in greater detail in a video introduction about organic chemistry. For now, they are just intended to demonstrate the similarity between migalastat, which is used in chaperone therapy for Fabry disease, and the actual target of the alpha-galactosidase A enzyme in the breakdown of GB3. We'll start our description of GB3 with ceramide, a group of basic sphingolipids. To make GB3 out of ceramide, we have to attach 3 sugars: beta-glucose, beta-galactose and alpha-galactose. On this slide from the second video, these sugars are depicted as circles with different protrusions. Those protrusions don't refer to anything in particular. They are just meant to show that these are not identical circles, but different sugars. Breakdown of GB3 happens in the reverse order, meaning that these 3 sugars have to be detached again. First alpha-galactose, then beta-galactose, and lastly beta-glucose. Each of these 3 steps requires a different enzyme. In this picture, the first of those 3 enzymes is depicted in a deformed fashion. Again, this is not literally what an unstable enzyme looks like. For one, the enzyme actually has to fit between those 2 sugars, which is where they are connected. Still, Fabrienne chose this depiction to be able to explain how the presence of something similar to galactose helps the developing enzyme to achieve its best possible form. Here are the chemical drawings of both substances to demonstrate the similarity of megalastat and galactose. This similarity is what enables megalastat to treat a number of Fabry mutations. So, does this mean that galactose should work even better? This conclusion would be equally invalid as the conclusion that megalastat must be better because it was developed into a drug and galactose was not. Comparing substances always requires comparing different aspects of those substances and listing the advantages and disadvantages of each of them. Don't expect the following comparison to be comprehensive. Fabrienne is a patient, not a biologist. For one, megalastat forms a stronger attachment to the developing enzyme than galactose does. This means that it has a stronger effect as a chaperone, which is a desired trait. On the other hand, the chaperone has to detach from the finished enzyme before that enzyme can perform its function, and in this phase of the process, a stronger attachment is an undesired trait. In biologists' terms, megalastat also has a stronger effect as an enzyme inhibitor. That's why megalastat has to be more carefully dosed than galactose. Some patients told Fabrienne that they experience the 48 hours between single doses of megalastat as too long. Available data on the pharmacokinetics of megalastat suggests that after 12 hours, over 90% of the total amount in a capsule is removed from the bloodstream. Possibly, the usual regimen of megalastat seeks to prevent accumulation of GB3. For symptoms caused by misfolded proteins, more frequent medication might be beneficial. It cannot be ruled out that some mutations can be treated with megalastat and not with galactose, but for mutations with a high but reduced residual activity, which are often left untreated, galactose should work as well. Fabrienne was told by patients with a D313Y and A143T mutations that galactose benefits them. Generally speaking, megalastat and galactose can be viewed as belonging to the same class of substances that function as specific chaperones that assist in the folding of alpha-galactosidase A. Now about other questions. All of the following answers are given to the best of our knowledge, but do not constitute medical advice and do not substitute a doctor's consultation. Because we mentioned the SGLT1 transporters in our last video, one Fabry patient was wondering if galactose can be used in combination with SGLT2 inhibitors. SGLT2 transporters are located mainly in the kidneys. The SGLT1 transporters that are of relevance for galactose absorption are located in the mouth and the small intestine. As far as we know, SGLT2 inhibitors do not inhibit the SGLT1 transporters, and galactose should be absorbed into the bloodstream just fine, even in combination with SGLT2 inhibitors. Some patients wondered if a higher dose of galactose than recommended by the producers is safe. We found further papers regarding the treatment of several other disorders using galactose. For example, 0.2 grams per kilogram of body weight twice a day are considered safe for the treatment of focal segmental glomerulosclerosis. The average Fabrian calculated from reports of Fabry patients is a bit less than 0.1 gram per kilogram of body weight 4 times a day, which would amount to the same daily dose. From a paper regarding the treatment of phosphoglucomutase 1 deficiency using galactose, we'd like to quote, "The maximum daily oral dose of D-gal any patient received was 50 grams, an amount that is within the recommended daily maximum intake and demonstrated safe." Is galactose bad for your teeth? Galactose is sugar, but it's different from sucrose. A recent paper suggests that galactose promotes the growth of healthy bacteria in the mouth and inhibits biofilm formation by damaging bacteria. It is even suggested that galactose might be used in oral hygiene products. Did you use galactose and not experience an improvement? Chaperone therapy isn't like a painkiller, with a quick effect that wears off just as quickly. Experience with migalastat shows that improvements set in after days, weeks or even months, depending on the symptoms. Hypohidrosis or food intolerances would only get better after years of therapy. As for galactose, we are just starting to gather information. And what about patients receiving enzyme replacement therapy? In 2015, the combination of ERT and migalastat was examined. It was found that adding migalastat to the ERT infusions improved the uptake of recombinant enzyme in a number of cells. This concept seems to have gained little traction, possibly because migalastat also inhibits the recombinant enzyme. A recent paper examining the combination of ERT and galactose suggests that this combination may at least delay the natural degradation of the recombinant enzyme. And that's the additional research on galactose Fabrian did over the course of the last few weeks. We hope it helps answer some questions, including ones you might not yet have had. Now, we hope we can turn to our main series again. As Fabrian is unwell, that will take time, but we will get there eventually. Until then, feel free to write and have a wonderful day.